So I am pleased to introduce this session on Banner Innovations and Integrated Care. Today we have Heidi Eccleston, who is the Senior Director of Program Development at Banner University Health Plans, and Dr. Sandy Stein, who's the Chief Medical Officer at Banner University Health Plans. So I'm going to turn it over to them for the presentation, and we look forward to hearing about their great initiatives.
Thank you. All right, well, good afternoon, and thanks for attending this session. And it's so nice to be here in person as opposed to on a team screen. But what we're going to cover today really quickly, because I know we don't have that much time, and many of you in the audience know me and know that I can talk too very quickly. If I'm talking too quickly, let me know. But we're going to cover the importance of an integrated approach, the current state of behavioral health, which is absolutely in crisis. Raise your hand, and it's not a team's hand, if you think the behavioral health community and access is in crisis. All right, so I'm seeing a lot of real hands grow up. We're going to address innovation and integration through clinical models, alternative payment modalities, and technology. And we're going to go beyond just telehealth and talk about app-based, evidence-based interventions and ways to successfully integrate and enhance access to care. I'm going to ask another question. Raise your hand if you've had difficulty in getting patients, members in for evidence-based behavioral health services. Okay, so a lot of people in the room, so we obviously need to figure out how we can work together and enhance access to care. And we know it's not one size fits all. So the current state of mental health in the United States, I've already given you probably my opinion that it's in crisis, but I've heard this all over the place in publications that I read. I'm going to go over some key 2022 data, and I'm going to go back a little bit to give you some history, but it's absolutely striking and I think heart-wrenching. So I'm going to start with some basic adult facts. In 2019, just prior to the pandemic, about 20%, 1 in 5 adults experienced mental illness. So we're talking about 50 million Americans. That's absolutely huge. And what we're seeing now is suicidal ideation is continuing to increase. In fact, every single year over the last decade, it has increased. And right now, we see about 4.6% of adults at any given time have serious thoughts about suicide. That's striking, it's alarming at a time where we see increases in evidence-based interventions from a technology standpoint, from a medication standpoint, from a physical health standpoint. We're going backwards. When you look at youth stats, they're increasingly alarming. A growing percentage of youth live with major depression. What we're seeing now is about 15%, and over 2.5 million youth have severe depression, and multiracial youth are affected most frequently. And I'm sure that's not a surprise. One of the things that you worry about with youth with major depression is that what is that going to do to normal developmental milestones? That's obviously going to set them back. So we already talked about the increase in behavioral health diagnoses that we're seeing, and now we're going to talk about the decrease in access to care, and this what makes a crisis. Over half of adults with mental illness, they receive 0 treatment. The percentage of adults with unmet needs has increased every single year, again, over the last decade. Over 60% of youth with major depression, they receive no treatment at all. And fewer than 1/3 of youth with major depression have consistent ongoing services. The rate of substance use is increasing. We're seeing what we call the behavioral health epidemic. Anybody hear this term? Usually associated with COVID-19 and that real significant increase in substance use and anxiety and depression. We're seeing obviously an increase in the opioid crisis and morbidity and mortality associated with it, and Arizona stats, and I'm not going to go through the details, but you have additional information in your slides, really concerning information. So I wanted to talk for a second about suicide and depression. So suicide is a major health concern, a public health emergency. Would you agree with that? Raise your hand. Okay, looks like everybody agrees with that. And the leading risk factor of suicide is untreated depression. And then we add in what we often see with our members or patients, substance use disorders, right? Physical health comorbidity, lots, social determinants of health. All of those exponentially increase that risk. And then most individuals with depression have never seen a behavioral health professional. And 50% of individuals who complete suicide, they've seen their PCP within the last 30 days. So think about that, a potential missed opportunity to screen, to refer for ongoing treatment. Depression and suicide, I want to make clear that this is an integrated issue that we need to work from a physical and behavioral health perspective on. I want to talk a little bit about anxiety and the physical health comorbidity that we generally see with anxiety. Anxiety disorders overall are the most common behavioral health disorder that we see in the United States. Pre-COVID, usually the data is about 18–20% of the population, 1 in 5, suffer from some kind of anxiety. The new studies post-pandemic, we're starting to see a significant increase. About 1 in 4 of every individual's children, as well as adults, is experiencing some form of anxiety. And I just wanted to gloss over the physical health comorbidity. We see GI disorders, chronic respiratory disorders, heart disease, and this is a key one. With cardiovascular disease, we see 2 times the amount of MIs with individuals with comorbid cardiac disease and anxiety, and with that, the mortality rate doubles as well. And if you look at the estimated ED visits annually related to anxiety, 1.2+ million. So you think about the dollars. Who's finance in the room? CFOs, financial people? Okay, so you're probably thinking, ka-ching, each of those visits is about $1,000, right? And then you look at the next stat, about 10% result in hospitalization. Think, ka-ching, how much is that? Maybe a psychiatric hospitalization, who knows, 10 days, $10,000, but it's a lot of money. Or physical health hospitalization as well. So overall, for behavioral health disorders, most behavioral health disorders, I think you see now go undiagnosed, untreated. Only 20% of individuals with behavioral health disorders see a behavioral health providers. And this is a key one. 50% of individuals that are referred for behavioral health assessment to a behavioral health provider from their trusted PCP, they don't access services. There are a whole variety of reasons. Maybe the system is difficult, maybe it's stigma, maybe there's no access, but that's where we really need to look and leverage technology and different kinds of modalities that we're going to be talking about today. Overall, behavioral health disorders are associated with comorbidity and elevated healthcare costs. So in summary, what we're seeing is the opioid crisis, but we can't forget about the behavioral health epidemic. The importance of social determinants of health is absolutely critical, and we need to be integrated and we need to be innovative. And I wanted to talk about this one picture here. Now, everybody says a picture is worth 1,000 words, right? I think this picture is worth 10,000 words. I remember back in the day when I was young and I was in medical school, I was in my training, and I know a couple of you out there when I was young and in my training, I thought that 20% clinical care there, if I learned how to provide good services and my patients or members had access to care, they would have the best chance at good outcomes. But now what I know is that's only 20%. All of the other stuff in that slide, healthy behavior, socio and economic factors, physical environment, all of those things have 80% impact on the overall health outcomes, length of life, overall quality of life. So on that note, I'm going to turn it over to Heidi, who's going to speak about some of our innovative pilots.
Thank you, Dr. Stein. So I'll tell you a little bit of what we did and why we did this. So why did we start this model? So as we all know, and been in the field for a long time, we have a lot of challenges with some of our most difficult to engage members. Not only are they difficult to engage, but they come with some of the most complex comorbid medical behavioral health needs. And so really when we started digging into our data, we saw that this subset of the population had high behavioral health, physical health complexities. They had high ED utilization, urgent cares. They also came with a high social, they had high SDOH needs and high readmission rates. So we said, what can we do? They're not engaged in services. They're hard to track. They're hard to reach through traditional methods such as telephone or coming into the clinic. So we said, well, we need to create some coordinated process across the healthcare delivery system. So we leveraged both our behavioral health network of providers, physical health providers, leveraged outpatient ED staff, and really looked at the community at large and to see where we could find some support to build these pilots that I'll go into. One of the great ideas one of the great things that we do here at Banner is we hold community councils. So really what we do is we bring our provider community, we bring community partners, we bring members, we bring families together to really hear from the people that live in those communities, what is the need in the community, what are some of the barriers in the community, so that we can work together in addressing those. So what was our approach? So we had 2 pilots going on. So we had 2 pilots which encompassed 5 providers in total. And so really what we wanted to do is bring these providers together and talk through what does this collaborative process and approach look like to really meet the members' needs. So knowing that traditional outreaches and traditional methods of reaching these really hard to engage members was not working, we decided we needed to create a boots on the ground approach. So working with the providers, we said, what would that look like? And so really it was meeting the member where they were at in the community. We know that this really difficult to engage membership, they're homeless, they maybe don't have a phone, or they're running out of minutes frequently during the month, or they're couch surfing between friends and families. So really we had to get people out in the community to find these members and engage them. Also, as Dr. Stein has mentioned, SDOH accounts for 80% of our total healthcare costs. So we really needed to ramp up what does that look like, what does that assessment look like, and how do we meet those needs when they're identified. For one of the pilots, we leveraged a local motel. We secured rooms via prepaid vouchers. So if they were working with a member that was homeless, starting to engage that member and really looking at, it'd be great if we could put them in a motel for a while, just so that we can kind of get them safe and really start working towards a transition plan. So we did secure about 5 rooms at a local motel in the community. Really, again, the approach was integrated, looking at the whole person. So assessing their physical health needs, assessing their behavioral health needs, assessing their SDOH, and really leveraging other folks in the community, peer-run organizations to really help maybe take a member to an appointment who needs that extra support, or take a member from the hospital home and stay with them for a while and really build that aftercare plan. And how did we do this? Because as we all know, a lot of these approaches are not billable under the fee-for-service model. So we engaged in alternative payment models with those providers and really looked at what would this look like, how could we cover the costs and make this meaningful, and ensure positive outcomes. So here's a little bit more, goes a little bit more into what I just talked about, but really what we looked at was the no wrong door approach. So any member was interested, any member the provider found that they thought could really engage in this program, they were enrolled. Really, it was intensive outreach. Engagement is key. It took numerous attempts to even engage these members. It wasn't as simple as, I caught them at discharge at the hospital, and yeah, they're great, they wanted to come into the program. It didn't really work that way. So we had slow approach to engagement, really understanding where that member was at. What did that member want to work on today? Not what did we think the member should work on. Also looked at a trauma-informed approach. We know a lot of our members come with past trauma, so really using that approach to slowly engage that member, earn that trust that they want to come and engage in services with that provider. And again, the member voice is always critical, right? They know themselves best, so what do they want to focus on? Again, as I talked about, some added supports was attending those appointments with the member, assisting with transportation. We had members enter vocational, employment, pre-employment programs and services, really getting that advocate or peer, and then securing those community resources to address those SDOH needs. So here are some outcomes. So these outcomes are from what we'll call Pilot 1. And so we had 74 fully engaged members in this pilot. This pilot ran from February through December of 2021. When we looked at those 74 members 90 days prior to enrollment into the program, they accounted for about 180 ED visits. And as Sandy said, if anybody's in finance, you can just see the cost of the rough estimated cost of that would be. Since their engagement in this pilot, through the February through December, we saw a 63% decrease in ED utilization with that boots on the ground, really working in the community with that member, a 73% reduction in inpatient behavioral health. And then what I really like, and I won't read through all of these, but was this 73% saw PCP, which when we looked at the data prior to enrollment into the program, 0% had any, in the last year, had any engagement, any sort of utilization with a primary care provider. So really, again, addressing those physical health needs that go alongside their behavioral health needs. And then as I mentioned in the previous slide, when one of the providers they tracked their data really well, but when we looked at how many outreaches it took for them to even just get the member to trust them or say, I need some help, on average it was 7 outreaches per member. So as I was talking earlier, it's that slow engagement, but that persistent, and really letting them know, I'm here for you. I know they gave an example once where they kept calling this person and just really trying to just build a rapport, and then the person finally said, you aren't going to give up, are you? And they were like, nope, we're not. And so through that, they got that member through the program and on a better track with healthcare. But then as we looked at, they were measuring their services that they were providing. When we looked at them, about 82.5% of the services that they were providing for this cohort of members were not billable services, which goes back to why we needed to create that APM approach in order to reimburse the providers for the great work that they're doing. This table talks about metrics and outcomes based on our second pilot. This pilot, the pilot 1 had the hotel rooms. This pilot was absent the hotel rooms. We did not have hotel rooms tied to this pilot. But 60 members participated in this pilot. And so what we did is we looked at utilization 6 months pre-enrollment. Then we looked at their their data or their utilization post-enrollment. And then the program ended in December of 2021. So since we had January through June, I said, well, let's look at what their utilization looks like when they're out of the program. Did they sustain those great outcomes and continue to decrease ER utilization, inpatient? And they did. So we have very positive outcomes, as you can see in the table. So for like ER visits, pre or post enrollment, we had a 34.5% decrease. And even into January and June, when the program's now over and they're in a regular care management kind of program with the provider, they continue to decrease ER visits, again, still moving that needle down by 30%. Same with inpatient from 61.5 and continue to go down by 55.8%. And then the last column is just a good estimate savings, but as you can see, this really hard work that providers, I know there's providers out there that do every day, it really shows, it really makes an impact on that member's quality of life, as well as improving the whole system of care from a cost perspective. And so this is just a summary slide of kind of basically what I just kind of talked about, but the strategy was very successful. Were there challenges to implementation? Of course, there's always challenges to implementation, but really finding that right provider partners were key for us, and finding those who want to do something different, do something out of the box, take a program they already have and tweak it a little bit to meet this need. So we had great partners in this, saw great results and decreases in ED and behavioral health utilization. Again, how do we sustain that? We need to think creatively around APM models, and I know we're doing a lot of that right now on how we can do this great work, since we know a lot of it is unbillable, to compensate the providers who the fee-for-service world is just not always going to work for some of these members. And then again, boots on the ground, no wrong door, and again, not one size fits all. Every member is unique and needs to be looked at that way, and a plan needs to be developed that way. And now Dr. Stein is going to talk about leveraging technology to provide evidence-based therapeutic interventions.
Great. And thanks for that great summary. I know that last slide said more to come, and the piece that's really exciting is we've partnered with many of you to leverage those pilots. We're going to look to many of you as we move ahead. More to come. I hope we can come back next year and share even broader information. But now I'm going to talk about leveraging technology to provide evidence-based therapeutic interventions focused on anxiety and depression. And I'm so excited to have people in the room. I keep on asking questions, but I want to see by a show of hands how many of you have had difficulty in having patients, members access cognitive behavioral therapy, evidence-based therapeutic interventions for anxiety and depression. Let me see by a show of hands. So a lot of you. So we need to do something different. And when we think about doing something different, I want to go back to that earlier slide where we talked about 50% of individuals that are referred by their PCP for services, they never show up. So this is really looking at leveraging technology and leveraging technology beyond just our focus on telehealth. So what we've done is adopted SilverCloud, and we're working with the provider arm of Banner as well, and really looking at digital therapeutics, app-based interventions. And we see that as an absolute essential part of innovation. And when we think about our model, we're obviously focused on the member experience. How do we make access to healthcare easy? Because it is really hard. One more show of hands. If you've tried to access healthcare yourself, raise your hand if it's been hard. Okay, almost everybody's hand is going up. So we need to make the member experience positive. Of course, we want to lower costs, have better outcomes, and in part, we want to make it easier for providers because providers are more and more burnt out, and it's certainly hard for us to get them engaged in our system. So this is treatment that's outside the four walls of concrete healthcare. So we know that care can be provided at night, in the middle of the night, on the weekends. We know that information can be sent to providers about how the member is doing, even when they're not going into the office. So this is very customer-centric engagement because the member is in control when they utilize the cognitive behavioral therapy apps. They're flexible options. It's usually about a 10-week module, 10-week program, but it can be shorter or longer depending on how the individual moves through it. There's 2 different tracks available that we're utilizing, one for depression and one for anxiety, and that's based on our selection for the pilot. And there's 7 modules in total for each of those. And with studies in a national center, we've seen significant lowering of cost with SilverCloud and other apps. And we know that there's a lot of data out there, and we really need to leverage the AI, artificial intelligence, and machine learning. So what is SilverCloud that I've been talking about aside from an app? We're utilizing it to address the gaps in care. I asked earlier who's experiencing gaps, and I saw an awful lot of hands go up in the room. What we're looking at with this app is the ability to address a full spectrum of wellness, mental health, chronic care, as well as COVID-19. But what we're focused on in this pilot is mental health, and we've selected specifically anxiety and depression, because that's where we're seeing our biggest increase, that's where we're seeing our greatest gap, and we didn't want to take on too much at one time. So how is SilverCloud accessed? Now I said this has to be easy for the member, right? And it has to be easy for the provider. So this is within a Banner EMR. Our EMR is called Cerner, and Xealth is a tool built into the Cerner EMR. So if a prescriber wants to prescribe any medication, Zoloft, Prozac, whatever they want to prescribe, it's easy in that Cerner system. This is a digital formulary, so at the same time, the provider can prescribe SilverCloud, so it's right in that centralized system, just a check mark. The order goes into the clinical record, and it automatically gets sent to the member. It can go to their email if they've requested it, or through the member portal. And then as they're utilizing that app, there's ongoing screening with the PHQ-9 and GAD-7 for anxiety and depression. So that office gets information back about how that member's doing. Are they doing well? That's great, we'll continue. Are they having scores that are decreasing? Are there concerns? Should we bring them back in? Should we continue this path or consider more traditional therapeutic interventions or medications? So again, it's easy, just like prescribing a medication, and it lands in the member's portal or inbox. That's cool, isn't it? Raise your hand if you think it's cool. All right, a lot of hands. So I don't have time to really show you the details of this, but what I wanted to show you was the login dashboard, and it's really easy, and you'll see the key words. It's very traditional cognitive behavioral therapy in an untraditional electronic setting. So the member lands on this front page, and we have it set up for anxiety and depression, and they can choose where they go. You can see getting started with basic understanding, psychoeducational classes, and understanding feelings and behaviors, and I'm not gonna read through all the modules, but all of the basic components of cognitive behavioral therapy. You can see a bookmark, the member can go back, the patient can go back, they can go forward to really study what's going on. And I wanted to show you another screenshot. There are personal stories that are built in there. This isn't a dialogue, but members can really go in and read other people's experiences so they can understand that they're not alone, because when we think about the stigma associated with behavioral health, too many individuals feel like they're different and they're alone. So this slide, I think, these next two slides, I think, are worth more than 1,000 words as well. This is data I wanted to tell you from Silver Cloud. It's not our data, but what they did was a study in looking at individuals, 235,000 individuals utilizing their app. You can see at the top, they're looking at depression with a PHQ-9. On the side, they're looking at anxiety. And right in the middle there, you can see that red area and mild to moderately severe anxiety and depression. So it's like a big comet. So look at that really carefully. Try to keep that in your mind. And now we're going to go to the next slide. Again, this is the data from Silver Cloud. And the follow-up, after completing the Silver Cloud modules, you can see the improvement in the depression as well as anxiety, and the decrease, so everything is bunched up into that, it's hard to use a laser pointer in here, but that minimal to mild range. Now that's really, really impressive. You want me to go back to that previous slide, or you remember what it looked like? You remember? Somebody said go back, so look at that, and look at that. That's a pretty set of pictures, right? So I tend to be skeptical, so we want to look at our own data, and we would really hope that we can get those same kind of outcomes. And our early data, it's early, but it's really positive. So we just started this pilot at the end of February. We've prescribed this about 220 times. And what you can see on the top of that purple is about 70 members accepted that. So 33% about members accepted the invitation to this app. That is so much more common than we usually see. The engagement is usually much lower. And then I told you that there were modules. At the end of each module, there's questions about, was the module interesting? Was it relevant? Was it helpful? Did you think you made progress? And you can see through all those responses in our study, about 95% of the time, they answered positive, that the module was very positive. They agreed or strongly agreed. Now that, to me, to lack of really technical terms, it's cool, it's exciting. And the data on engagement, this is so positive. Now look at this, the average number of logins per user is 9. We talked about that there's 7 modules, so they're going back. And it usually takes about 15 minutes to actually go through a unless you're going back and forth. The average duration, 15 minutes. So they're spending the time to go through those modules, and the total time logged in, over 2 hours. So they're getting a lot of basic cognitive behavioral therapy. So I wanted to share with you our early outcomes. Now I wanted to say, obviously, the N is only 38, And I hope we can come back next year and say the N is a lot bigger and we have the same results. But if you can look, this is for anxiety, the GAD-7. Before treatment, about 55% of the individuals had moderate to severe anxiety. And after they completed the modules, that went down to about 25%. So a decrease of 30% with moderate to severe anxiety. And then we look at the minimal, we can see that's increased by about 20%. So there's a huge amount of progress with this module. Who thinks that that's pretty cool? Lots of people. You want to see what happens with depression? So if I can get it to move, there we go. Depression, we've seen almost the same thing, same N, 38. And if you could see the data is separated differently per the scoring of the PHQ-9 that you're all aware of, but we took moderate, moderately severe, and severe. That added up to about 55%, and after completing the module, it ended up being for those same categories about 35%. So we had a decrease in the severity of about 20% with that same increase in minimal symptoms as we saw for anxiety. Pretty cool. So I'm really excited about that. I think Silver Cloud, and I know there's many, many apps out there, but we have to look towards these because we have workforce issues. We need to be able to have our psychiatric providers here, really complex members, right? And there's a lot of individuals that we were talking about early on when we went through the data with anxiety and depression. Silver Cloud offers flexible care. It offers evidence-based interventions, cognitive behavioral therapy. I can't tell you how many times I've gotten calls, Dr. Stein, we can't get this patient, we can't get this member in for evidence-based services for cognitive behavioral therapy. It's easy for the prescribers to prescribe it, which is critical, otherwise it's not going to be used. It's easy for the members to access, which is also critical. The national statistics, really positive. You know, there's Sandy that's a little bit cynical. I want to see our banner statistics, but our banner early data, it's really impressive. I'm very excited by about that. So we really need to leverage technology. We need to go beyond just telehealth, which is critical, but to really look towards how we can expand our workforce in new, innovative ways, and much more to come with Silver Cloud. So overall, I know we said we'd action pack a lot into this and we wanted to save a few minutes for questions. Let's see if we did this. I think we're right on time. But there's many ways to innovate and integrate. Certainly, we're talking about clinical pilots, we're talking about payment strategies, we're talking about technology, innovation, and integration, right? The following strategies, we always have to think about lessons learned from COVID, because the world will never be the same from a healthcare perspective or for any perspective. Certainly, if you told me 3 years ago that about a year ago that I'd be sitting in my room doing my work, my kids would be in their rooms doing school and wouldn't be out in the world, I would say, I don't believe you. The world has absolutely changed. Who would have believed that the world would have changed like that? It's incredible. So we have to leverage a range of technology. We need to think about telehealth all of the time, but going beyond telehealth, we need to also look at clinically integrated network design, which is, I wish we had more time to talk about that today, certainly focusing on behavioral health, physical health, and social determinants of health, and we need that broad continuum of care. We need the services that all of you provide, and we're really excited to be able to work together with community providers. And we learn a lot from you. We need that close collaboration. We need alternative payment methodologies. And in all of this, we're learning, because this is all new ground. This is a role of performance improvement in a clinical setting. The world is our learning laboratory. So on that note, I'm going to stop talking, see if Heidi has anything to add.
No, I can.
All right, and I said we wanted to save some time for questions, so I think we have a few minutes. Thanks. I appreciate the applause. I would imagine there's some questions, and if you all have a question, great, there's microphones, and I'm going to repeat That's what I've been instructed to do, so folks, I guess, can hear it clearly, and it's being taped.
So when you talked about Silver Cloud, you talked about the integration with Cerner. So as your members are accessing that application, are there certain discrete data elements that then connect back into Cerner so that
Yes.
at the provider's fingertips, they have that information easily accessible? Or can you speak more to how those systems are interconnected and how data flows?
Yes, I'm going to try to repeat the question and let me know if I got it right. The question was, when individuals are utilizing Silver Cloud, does data get back into Cerner, and how does it get to the provider? How does it get into the EMR? Did I basically get that correct? Okay, thumbs up. So what ends up happening as the individual utilizes the Silver Cloud app, the data gets fed right back through the Xealth app. And probably your physician provider isn't going to have time to go in and really look at that data, but their team's set up to see who is the person on that team that's going to access that data. Is it going to be a nurse? Is it going to be an MA? But they're looking at that data, and then there's going to be a team-based meeting, and different offices are utilizing it a little bit differently, but to really talk about the scores for individuals in general, or if there are key concerns. And they can just look at the data if they want quickly as well, but there's that exchange loop to make sure that the data is being utilized. And that's where I said, if a member isn't doing well, they may be brought in. We may add additional interventions like more traditional therapy, more assessment, potentially psychotropic medications. Does that answer the question? All right, thank you.
This is another Silver Cloud question. I was wondering how you engaged your providers and the staff in supporting patients that were using Silver Cloud.
Yeah, that's a great question. The question, and you tell me if I got it right, is how we engaged our providers and staff to utilize Silver Cloud, correct?
Mm-hmm.
So what we did is we engaged 5 primary care offices across Banner. And the way we engage them is pretty simple. When we're really fortunate at Banner that the insurance division works really closely with the provider arm of Banner, and we always talk about care and coverage. But when I talk to our PCPs, I hear, I'm always saying, you got to screen for depression, which most of them are doing, but you got to screen for at least anxiety too, and probably substance use. And they tell me, Sandy, you're always telling me you want us to screen, but we're terrified. If somebody screens positive, we can't get them behavioral health services. We don't know what to do. So we engaged 5 practices and said, okay, for your mild to moderate, moderately severe individuals, if you screen them, we're going to give you use of this app, and each practice can determine how they're going to actually use that data, because it's provided right there for you. But again, the actual providers, the physicians, probably aren't the ones that have time to look at that data. So they were really excited. So then they said, Sandy, okay, you're giving me a tool that I know is really accessible. So they were really thrilled. And obviously we're in the really early stages, but they're thrilled with the engagement. That's 33% engagement, which is really tremendous. I mean, we hope we keep this up with a larger sample. And you saw the outcomes. They're really exciting. Does that answer your question?
That does, and it brings up the other half of my question, and that is 1/3 engaged, 2/3 did not. What do you know about the non-engagers, and are you targeting them in any way?
Yeah, that's a great question. We haven't done any research into the non-engagers, but what is going to happen clinically for those non-engagers, the team will reach out to do ongoing screening and make a determination. Do they need to come back in? Do we need to provide basic interventions in a primary care office? Do we need to refer them to a behavioral health office? And if they're referred, they've heard me say a zillion times that we know if a patient is referred by a PCP to their behavioral health provider, more than half the time they don't show up. So we're making sure that there's a warm handoff and more engagement, and really closing that loop to make sure that member ended up accessing those services. So that's as far as we've gotten. Thank you. Another question, and I
Hi.
know we only have a few more minutes. I have time for this? Okay.
Hi again, Dr. Stein.
You always give me hard questions.
Well, I'm going to get in the weeds for a minute, so just bear with me. But the opportunity that you're presenting around the use of technology is a great one. And unfortunately, in the work that I'm doing around consulting practice, if you will, is that a lot of entities are not clear on workflows about how this gets integrated. So just real specifically, who's explaining the technology app to the patient, which kind of gets back to, are they consenting, and then maybe why there's a 2/3 that are not saying yes.
And I didn't completely hear the end of the question.
Who explains Silver Cloud to the
Oh.
patient, which might be part of seeking consent, which might lead to why they're saying no 2/3 of the time?
Right. So who is actually providing information about the
product?
About the app? The clinical team is. So it varies from practice to practice. We wanted to leave some choice. In some practices, it's actually the doctor, the PA, the nurse practitioner that's prescribing it is saying, okay, I see you scored high on JD9, PHQ. And they'll explain the module, that it's going to be sent to their email, it's going to be sent to their portal, and they provide a little bit of information. Usually it's the nurse, it's a physician extender, it's the MA, and I think you hit the nail on the head that it depends a lot on the person who's doing the engagement. I can't tell you how much it hit me. We're obviously focused on CAPS and member experience. I think, raise your hand if you're involved in that. And it's so critical. I called a physician office the other day, not a Banner physician, it was on personal side, to get an appointment for a family member. And the person that answered the phone was so rude. And I was asking basic questions, and I thought, wow, I'm not going to have my family member see that provider. And I know that provider really well, and I called them. But there's so many ways, there's so many variables. So if that individual isn't engaging the right way, they're never going to utilize the app. So it's a great question. We don't have eyes and ears on that. It's a great question. And I don't know if I repeated that, so I apologize if I didn't. I guess we're out of time. One more question, if there's one more question. Doesn't somebody want to give Heidi a question?
No.
All right, your last chance. All right, well, thank you very, there is one more question at the last minute. You don't have to run.
I just wanted to know, in that program that you were talking about, in that pilot, how many people did you have in that pilot program that were working that pilot?
How many people did you have in the pilot program?
In pilot 1 or pilot 2?
Either one?
Either. So pilot 1 was 70. Yes, and pilot.
And not members, but actually working with
Oh,
those
how
members.
many? Well, in pilot 1, there's 2 providers working for 70 members, and in pilot 2, there was 4 providers for 64 members. So roughly, each provider had about 15 to 20 members that were in that program at any given time for that team, which was usually a care manager and a peer working simultaneously together for those members.
Thank you.
And I just wanted to add one thing. What was really exciting when we talk about pilot 2 was there were 4 different providers, and we had similar, very positive results across those 4 providers. That makes me think we can further expand that. Thanks. I'm glad we got Heidi a question, and on that, I think we're officially out of time. I want to thank you for all coming. I think my information is available if you want to reach out and ask Heidi or I any additional questions. Thank you.